All right, Dr. Bradley, I think we're ready to go.
All right, we will go ahead and call the meeting to order at, I think, 12:01 here. Shelley, I will hand it over to you for roll call, please.
Amber Rice,
Here.
Dan Spate,
Dan's here.
Franco Castromarin,
Present.
Frank Walter, Dale Bradley,
Present.
Eve Godsthinker,
Present.
Jason Johnson,
Here.
Rasha Gaither,
Present.
Julie Augenstein, and Kevin Foster. I count 7, we have quorum.
All right, thank you very much, Shelley. Just a couple housekeeping reminders that I did forget for our first 2 meetings, but everything said is part of this meeting is part of the recording, which will be posted to the Bureau's website. So please keep all comments quiet as possible. Also, we are the private caller on the Google Meet, so if you see background noise that is the room audio, please do not mute us. We had a couple meeting attendees that kept muting us in the last couple meetings. So private caller is the room audio, so please let us stay live with the audio. Attendance report is in your packet. So just a reminder, if you missed 2 or more consecutive meetings, the Bureau will reach out to you to see if you would still like to participate as a member of this committee. We have 2 current vacancies. First is for a physician who specializes in severe acute head injury treatment or spinal cord care and has interest in EMS services. And the second is an emergency physician serving an EMS council from the Western region. If you're interested in either of those roles, you can submit an application to the governor's website, specifically go to the boards and commissions section there. Again, we know that there are some transitions with the new administration, but we do anticipate we will hopefully get some new appointments moving forward. Next on the agenda, just a reminder about FR-CARA. As I had kind of said in the last several meetings, we are really trying to help publicize and move this grant program forward. We are very fortunate to now have someone who's FTE Sebastian, who's here with us in the room today, who's going to be kind of dedicated to this program. Our first grant was really looking at law enforcement and EMT only, naloxone administration. Our focus moving forward is going to be on helping to develop more of a statewide naloxone leave behind program, and we anticipate within the next 2 to 3 months that we should have something ready to go live. Once that is ready, we will make sure that gets advertised in multiple different formats, and we will definitely share more with you at the next meeting in May. Next for the Bureau report, I will turn it over to Chief Garcia. Thank you.
Good afternoon and Happy New Year. I don't have any new updates for this group that we haven't already shared since the meeting this morning. But really quickly, I'll reiterate if anybody new is on the line for the recording. Legislative session has started and Governor Hobbs has appointed a new ADHS Director. Dr. Teresa Cullen from Southern Arizona will be joining us. She has started engaging with state leadership, and we look forward to having her in the ADHS Director role moving forward officially next month. With respect to legislative session, ADHS is not sponsoring any bills this session, but we do remain available to all stakeholders if you do have any questions about legislation that impacts the EMS or healthcare communities. The department right now is working on rule reviews. By statute, we have to review our rules and administrative code every 5 years. And we are, after completing our rule reviews, seeking approval through Title 41 to update rules for ground ambulance, EMCT certification and training, and potentially trauma rules. If we receive approval to open any rules, we expect the rule writing process will be limited to what we are able to do, of course, in statute. For some of the rules, it likely would just be to clarify some really simple language. But for EMCT certification and training rules, we have had interest with respect to developing a critical care paramedic pathway. And if we're able to move forward on that, we will definitely be trying to put together a work group with stakeholders and soliciting additional input for for any rule updates moving forward, you can expect that we will be keeping our stakeholders and especially our committees informed of where we're at in the process. And any draft rules will be posted on our website and available for a public comment period. So more to come on that. Two quick plugs that I think we will get into a little bit more detail on later, possibly. We are working on a needs assessment. There is going to be a needs assessment survey link that is going to go out to all of our EMS and trauma stakeholders statewide. We are asking the regional councils to help us push this out throughout each part of the state. And the survey is important because it will help inform our state EMS and trauma strategic plan, and it can also potentially help influence future funding requests. So thank you in advance for everyone participating in that needs assessment. I think Julia shared that it will be available at the end of this month or early next month. Stay tuned. The other piece that we have been sharing throughout today is that there is a new EMS and trauma portal coming soon, and I will be quiet since we are going to pull that up a little later. That's all I have for now. I'm going to go ahead and introduce some of our new staff, though, that are in the room. We have Brian Hubble, and he's our new CLN and rates manager. We also have Sebastian Thomas, who we introduced as part of the FR grant. Thank you both for joining us. Not in the room at the moment is also Jeff Kerr, our new compliance and enforcement manager for the Bureau, and we are thrilled for you all to get to know them.
All right, thank you very much, Chief Garcia. Next, I will hand it over to Julia for a share update.
Thanks, Dr. Beth. Just a couple of updates. So the shared team at the Arizona Emergency Medical Research Center is continuing to collect and clean hospital and EMS data from 2022. Thank you to everyone who is working on submitting data. Updated cardiac receiving and referral center lists are posted on the Bureau's webpage. Most recently, the Bureau recognized 2 new referral centers, Faro Valley Hospital and Honor Health North Crossing. Lastly, the shared team is looking into the possibility of hosting some in-person meetings in coming months. If your agency would be interested in learning more about the SHARE program, how to utilize SHARE reports, etc., then please let us know. That's all.
Thank you, Julia. Next, if we can bring up the EMS annual report and specifically the snapshot. Thank you. So just wanted to cover this. We did go over this in the last 2 meetings, so it looks like we have slightly different attendance for this group. So this is still in its draft format. This will be finalized and published here hopefully in the next few weeks. Just a reminder that the 2022 report is based on 2021 data. Part of the reason for that delay and lag time is the fact that when we go to link that data to the hospital discharge database, that data is slower coming in than what we get through AZPers. So just a reminder that this is the 2021 data. You can see here, I'll go through this just kind of briefly. Initially, EMS reports reported to AZPers. There was just over 1.2 million and just over 1.1 million incidents that were included in the analysis. Looking at certification numbers, for 2021, we had 21,773 EMCT certifications and around 2,500 new certifications that were completed. Just for everyone's awareness, for the team that handles certifications, both initial and renewals, this is a huge workload that they accomplish amongst 2 of them on an annual basis here for the state of Arizona. For 2021, we had 179 EMS agencies that submitted data to AZPers. This has gone up since then. And you can see here the average number of EMS incidents per day, just over 3,000 calls. 2021, we have seen steadily over the last several years, both due to population increases and just increasing acuity and volumes, that we are seeing 911 call numbers increasing, and this is reflected in our AZPers data as well. You can see also the breakdown between our 911 responses as well as interfacility calls, and then also breakdown of age groups for patients 0 to 17 at just about 6%, and greater than 55 years of age, it's just over 55% of the group. One of the requests from our last time was to include the prevalence of primary and secondary impressions of interest for the pediatric patient population. You can see here that we have injury for pediatrics is about 19% of EMS calls, so a pretty significant number. Respiratory distress, 8.6%. Seizures, which is interesting when you look at the comparison, For pediatric patients, seizures, it's just over 6% of EMS calls. When you look at all age groups further down, we'll see it's just over 2%. So certainly a higher number of calls in that age group. And when we combine psychiatric disorders, substance use, and suicide, you can see that those numbers decrease just around 10% of EMS calls for pediatric patient population as well. When you evaluate county-specific data, this is per patient population, so the map on the right, you can see when you are kind of correct for residents, La Paz County has an extremely high rate per patient population for their 911 incidents. And our medium time intervals for the calls, you can see here again, just recognizing that this is statewide data, so both urban, rural, and suburban areas, and all different types of jurisdictions. Your average response time is, or median is 8 minutes, 12-minute scene time, and 11-minute transport time across the state. Scrolling a little further, this is the prevalence of primary and secondary impression categories of interest. Again, you can see here for our staff meeting this morning, we had a really nice presentation from the Arizona Fall Coalition and looking at kind of how falls impact that. So looking at overall injury, when you combine substance use disorder and psychiatric disorders, again, all age groups, pretty significant number there, over 7% of calls. Seizures, again, that contrast is 2% for all age groups versus 6.4 for pediatric, and our cardiac arrest numbers. Then bottom part, we have our mortality. You can see here cardiac arrest numbers and expected a pretty high mortality rate. We did see through the pandemic that our cardiac arrest outcomes and mortality numbers increased, which is really felt to be multifactorial. This was correlated with the data that is obtained through the SHARE program as well. We will be interested to see, as we hopefully move out of the pandemic, what transitions we potentially see in our cardiac arrest outcomes across Arizona. Opioid overdoses, you can see they're on a 13% mortality rate, STEMI 8%, stroke 5.5%, and diabetes 2.5%. So just kind of a brief overview of the data here that we wanted to make sure we shared with this group. Moving forward, one of the things that we've discussed with the last two committees is the staff report is kind of required in statute, and we will continue to produce that. But Boswell and her team have really done so much work putting together the real-time 911 dashboard, if we can bring that up here. And so we really want to consider moving away from a kind of written format and kind of emphasizing more time and energy on things like this. So we've got for real-time 911 dashboard, and you can see here the data is from January 8th to the 14th. That's being displayed. You see the call volume. Thank you for Dr. Castamarin, who clarified in the last meeting. When we look at 911 call volume, this is calls of patients that get reported to AD peers. So we do have the majority of EMS agencies to report data, but we don't have access to just the 911 dispatch center calls. But you can see there the call volume, number of cardiac arrest, STEMI, stroke, falls, pretty dramatic number, recognizing what a large percent of our calls are fall related. For EMS providers. And so really, are there opportunities kind of looking at how EMS could be involved with that moving forward? So this is, the real-time dashboard, but we also have a number of Tableau dashboards that Boswell and her team have developed. These can be queried based on different types of things, whether it be criteria, other medical conditions. You can kind of do different searches, adjust it based on your region, your county, et cetera. So if you have any questions about how to access the data, please let us know. We can point to you where that is in our website. But just wanted to mention to all three committees that we really want to look at potentially moving forward, transitioning from this kind of a little bit delayed written format and report into some of this more real-time data. So any thoughts from the group on that?
Sorry, I can add in my thoughts. I've used the interactive Tableau dashboard a good bit. I found it very helpful, extremely easy to navigate, much more useful than the annual reports. So I think from my perspective, using it mostly for grants, research questions, resource deployment type of questions, I found the Tableau dashboard very, very helpful, much more so than the annual report.
Thank you for the feedback. Any thoughts or feedback from anyone else in the committee? All right, hearing none, we will go to our standing committee report. I don't know if Dr. Augenstein has had a chance to join us or if there's anyone else that can give a TEPI report.
can pinch hit here.
All right, thank you, Shelley.
At the last TEPI meeting in November, they approved their minutes. Also went over some ground level fall with hip fracture data. Of course, looked at the 911 data again. Talked about potential trauma data projects. Bruce Barnhart gave a comprehensive share report on the data they're collecting. Discussed the trauma registry needs with the providers, and then they had to table the ASDR public data set age groups topic. End of report.
All right, thank you, Shelley. If anyone is interested about the ground level fall and hip injury report, this was an ad hoc report that was requested by some of the TEPI members, and Vossel had put together for that. And I think we should probably add that to the agenda to bring forward to the statutory committee meetings in May. It was really interesting data. One of the things identified was many ground level falls with isolated hip injuries are transported to non-trauma centers very appropriately. But when we look at our trauma report, the trauma report is capturing data specifically from trauma centers. And so the trauma report grossly underestimates the number of ground level falls with associated hip injuries based on that. And so I think it was a really good report that she pulled together. So we will make sure that we bring that forward for the next round of meetings. So thank you for mentioning that, Shelley. Next up for Education Committee, Dr. Johnson.
All right, so at our last meeting, we went ahead and approved the national guideline for EMS field triage of injured patients, and as well as the pre-hospital death notification. We also approved the draft training for the STR for EMTs and CPAP with some edits for clarity. Then we went ahead and formed a work group because we need to review the posted training on what should go in your EPCR, and we're scheduled for that work group on the 1st of February. There's another work, another work group scheduled for the 8th of February to develop the supraglottic STR training. And then we discussed a little bit about the community permits and that Chief Garcia had already mentioned.
Thank you. Big thank you to our Education Committee. They do a lot of work under Dr. Rice's leadership, really putting together these training curriculums for agencies to utilize. So big thank you to Education Committee. Next up, Dr. Dacer for PMD reports.
All right. Our last meeting, also November 17th, chaired by Dr. Castamarin. At that meeting, we discussed several initiatives. The first was making diltiazem required. No action was taken on that, so that issue was tabled. We also requested a work group to help develop, not a work group, we requested some help to develop drug profiles for Tylenol and Motrin. Brian Smith volunteered to develop those drug profiles and bring them back to the group. We also approved the formation of a work group to consider the expansion of Drug Table 3. There were several items that are to be considered, and that work group will bring those recommendations back to PMD. We did vote to make methylprednisolone or dexamethorphan as either or rather than both of them. That is up for discussion later today. We discussed adding IO to the EMT scope of practice as an STR. No further action was taken on that item. And then we also voted and discussed on making an all-day special meeting to complete the T3Gs, which we will discuss later today. That's it.
All right, thank you very much. Next up, Adam, for a PACES update.
Hello, everyone. This is Adam, your EMSC. So at our last PACES meeting, the training gap work group decided on seizure education, and so a module was brought forth for the Education Council agenda for approval as a training item. So that will be on the next Education Council meetings agenda. The Behavioral Health Work Group is being sunsetted after we make the edits to a module for pediatric behavioral health training. Also in the last meeting, we're sort of making new room for the EMSC grant goals, which are to stand up an EMS pediatric recognition program. Lastly, we'd like to thank Chris Ramos as he's accepted the vice chair nomination. So we look forward to working with him. I'm available for any questions. Okay, thank you.
Thank you, Adam. Next up, if we can get a motion to discuss, amend, and approve the MDC meeting minutes from September 15th.
Motion.
Thank you, Dr. Gasparin, and second, Dr. Johnson here in the room. If we can scroll through those, Shelley. These are in your meeting packet as well. Any recommended amendments to the meeting minutes? So it's motion on the table. Anyone opposed to the meeting minutes, please say nay. Any abstentions? All those in favor say aye. Aye. All right, meeting minutes are approved. Thank you. Next, I will hand it back over to Chief Garcia to discuss the EMS and trauma online portal a little bit more depth.
All right, I think we have 2 screenshots to share with you all, and we just want to make sure we continue to promote that this spring, potentially as early as March, we're going to be updating our EMS portal. That's the portal that a lot of folks are familiar with. It's the ems.adhs.gov website, where you currently can go to renew your EMCT certification. This new portal that you see here is going to be hosted by ImageTrend. It will still offer certification services for folks to go in and renew or apply for a new certification. But we're excited because it's going to do a whole lot more than that. We're going to have a link to our base hospital and trauma center portal as well for people to log in and use more online services. Our hope is to be able to go away from paper applications and move towards online applications in the future. And we really think that this type of a self-service portal is going to be a huge improvement. If MDC has any questions, we're happy to dive into this further in the future. We're going to lean on our regional councils quite a bit to help promote the information about the new portal, how to log in, how to use features. If you are an ambulance service, EMS provider seeking certification, base hospital, trauma center, training center, there will be services in here for folks to come in and do that self-service. There's one more screenshot, and I think it's just teasing that when you log in, you'll have your account information, and we will definitely be sharing more instructions as we move forward. That is all I have for now, unless there are questions.
I have a quick question. Do you have a list of what's going to be offered through this portal? Like, this is where you go for your X, Y, and Z? Is that you could share with the group, or particularly for those of us on regional council, we can push out?
Yes. So our hope is to be able to share first information on how to log in, so everybody, especially those that have an account currently, can still access the portal. And then secondly, that list of all the services that will be available to so many of our providers that we work with. I know a lot of our folks are just used to, most of our stakeholders are just used to picking up the phone and calling directly and submitting paper applications. And of course, we will still offer that same level of customer service for all of our stakeholders because that is what they are accustomed to. But we can't wait to share that list with you, Dr. Gaither, because I think that many people will find it very helpful to have the portal to go to and navigate those sort of things. So that will be coming next, and we will lean on Spain and the other 3 councils to help get that out.
Any other questions or comments about the upcoming portal? All right, next I will hand it over to Dr. Gaither for a final update on the pilot project for ultrasound guided IV. This, again, was a reminder, was kind of a bridge to the scope of practice update, but I think it was pretty impressive with the amount of data you were able to collect. So I will hand it over to you, Josh. Thank you.
Yeah, so this is super fun, super cool, and thanks to everybody for, one, approving this as a pilot project and letting us go for this. So I want to acknowledge the contribution of our other people who did a lot of work on here. Dr. Josie Acuna is one of our ultrasound faculty who helped put together the surveys for this, and Wyatt Schnell is a med student who helped us pull all the data. So I'm going to just run through this. This is really short, short, sweet, and good. First, hats off. I cannot actually believe we had 26 sites participating in this study. That's a huge number of hospitals. And again, a thank you to the medical directors and staff who did the education and training for our medics. As a review, the ask of this project was that if the hospital wanted to participate, they needed to train their paramedics on how to place a peripheral IV using ultrasound. They had to do some type of competency verification, generally observing 3 sticks using ultrasound, and then the medical director had to attest that they were willing to do that and submit cases through our QR code survey. So these are the hospitals that participated, and again, a huge thanks to them. Next slide, there you go. So here's the results. We had 161 completed surveys. That is a ton of IVs placed. And a remarkable success rate, 96%. I can't remember the exact numbers, and the slide's too small to read, but it was about 40 failed cases in that entire set. So remarkably high success rate. If you go to the next slide, we'll dive into a little of those placements. Again, I apologize, too small to see, but where were they placed? I was actually surprised by this. The vast majority were placed in the forearm. That's that top bar there, more than 50% in the forearm, which is atypical, at least for the physicians in the room who place ultrasound-guided IVs. The second one was antecubital fossa. Again, traditional place where we put IVs, and a very low-risk area. The bottom two were brachial or above, and obviously much lower frequency of being placed up there and higher risk, which is, again, encouraging. This is what I'd like to see in IV placement. Switch over to the next slide. We'll look at some of the failures. This is the number of attempts it took to place. So 1,021 were placed in the first attempt, 36 in the second attempt, and 1 on that third attempt. This does not imply success. So just if they made 2 attempts, they may not have succeeded. So these are simply the number of attempts made. Perfect. Let's hit the next slide. Here's the complication rates. No arterial punctures, which is probably the one we worry about most. It's easy to do using an ultrasound to identify the wrong vessel. There were some hematomas, infiltration, and other. If you really squint, you can see the asterisk down there. Of those 8 that were listed as other, 5 of those were actually, they clicked the wrong button, and in the comment they said there was no complication, I just clicked the wrong button. So that's actually a 3 of the other. That ends us up with a less than 2% complication rate, which is right in line with what we see from other peripheral IV placements using traditional landmark methodology. I think there's one more slide up there. That's it. So I wanted to conclude with, of course, a thank you again to all those medics participating, and then my interpretation of this before I turn it over to you for questions. If I look at this from my very academic eye, this is a great database in that it shows paramedics placed
fucked up.
peripheral
No, I
IV.
had my own updates, but they just came off terribly.
Unfortunately, it does not show us that every place that implements a peripheral ultrasound-guided IV placement program will have a success rate of 96%. The severe limitation of this data is that it is self-reported, and clearly there's the potential for error introduced into this due to paramedics not reporting unsuccessful attempts. So really interesting data. It was a great project, and I appreciate all your support. And with that, I'll turn it over for any questions.
I've got one. Just out of curiosity, do you know of, it's a 2-part question. Do you know of any other states that allow paramedics to do this in the field? And with this success rate here, I know it's just a pilot project, would you anticipate the ultimate goal is to get this on the ambulances or keep it in the ER?
So 2-part question. Let me do the first one. Other states do allow paramedics to use ultrasound guidance to place IVs. Every state has their own unique approach. In some states, that's very medical director driven. So in some places, that is allowed. I think the operational limitations of peripheral ultrasound guided IV placement are what will limit its application in the field for us. Currently, even the most expensive ones are fairly expensive, and for those of you that have done this, it actually takes a long time to get your ultrasound set up, to put the gel on, to clean it, all that stuff. It's much, much quicker to place a blind peripheral IV. So again, my personal clinical gestalt, I think it has less utility in the field. That said, there may be some special places in which it is helpful, perhaps critical care transport, where you're dealing with patients who have volume depletion, other things that make traditional ultrasound or IV placement difficult. So, yeah, it's interesting. But there's a total side note, there's a whole pre-conference at the National Association of EMS Medical Directors on this topic this year, so I'm looking forward to that. It should be interesting to hear what they have to say there.
Meaning ultrasound in general or ultrasound IV?
Pre-hospital ultrasound, yeah. Yep. So.
Great data presentation, so thank you. So again, I think this is our first pilot project that we've put through this new process, which is to have that proposal come to MDC. So big thank you to MDC for number one, kind of considering the proposal. I think the hospitals really appreciated that. And this is what we'd like to see moving forward with any pilot project, but it really be focused of MDC as the governor's appointees to kind of guide EMS practice in the state, make a recommendation to the director as to whether or not to approve a pilot. And this is, I think, a really nice example of bringing that data back to this committee so that we can make further recommendations moving forward. So a big thank you for experimenting through this process with us, Josh, and for everyone that participated. So nice to see this process working. All right. Next on the discussion action items, if I can get a motion to discuss, amend, and approve and edit to Table 1, EMC drug box to show dexamethasone or methylprednisolone.
So moved.
All right, I see a motion in the room from Dr. Katzmarin, second from Dr. Gaither. Thank you.
I'll start the discussion. This seems like a no-brainer to me. These are the very similar drugs. Why would you carry two? I love the or. Great idea.
I agree. I don't know if there's much to really discuss. It's pretty straightforward.
And then just to make sure that we are matching the item as listed on the agenda, list them as being optional, but what's being put up on the screen looks as it's required you would have one or the other. Correct. So I just want to make sure that the action item matches what is put forward. I realized that as I was reading it a little bit more carefully.
Yeah, we had initially discussed that it was written as being an optional thing, and then we had discussed that we needed to keep it one of them as being required. So that looks correct.
So just, do you want to make a friendly amendment to make it to have it be required? Or do you want it to read as optional, just to make sure, because if we're going by the action item on the agenda, I just want to make sure for.
Isn't it listed on the agenda as being required?
The agenda says optional.
Oh.
So I just want to make sure, the way it's being projected right now,
Yeah.
it would be a required agent. I just want to make
Which
sure
I think,
that.
so I would support that friendly amendment. Currently, looking at the drug table, methylprednisolone is required and dexamethasone is optional. So we would need to keep one of those as required. If we make this change. So I think that's a friendly amendment for myself.
I think that was the intent.
Yeah, that's how we discussed it.
First, is the question?
Can I just make a comment, and help me here if I'm not understanding. Recently, we had an agency call and say that they didn't have one that was required, but they had an optional, and they wanted to use that optional, like in substitution for the required. So is there something that we can make clear, because they were told you cannot substitute one for the other, so leave it as or?
Yes, so the recommendation, that's kind of the feedback for this new, this format allows them to use one or the other. When they're on separate lines, you cannot exchange. So historically, many years ago, we had each drug, like if you looked at the benzos, we had lorazepam, separate from midazolam, And so each one you couldn't be exchanged. So this new format does allow an agency's flexibility if there is a shortage or they have a choice to choose one or the other. So this, I think, would address that for them.
Okay, perfect. Any further discussion?
This is Dan on the phone. There's been enough permutations discussed. Could you please let us know exactly what it is we're voting on?
Yes, absolutely. So I think the proposal with the friendly amendment is to change from dexamethasone being optional and solumedrol being required as two separate drugs. The new proposal would be dexamethasone 8 milligram or methylprednisolone 125 milligram, one of which would be required.
And just another quick question: Did anybody happen to look into AZ peers during the process of this snooping through this one? Look in AZ peers to see how often either of them are used, because I think just as a matter of philosophy, now that we should have access to large volumes of that data, it does make sense to me that when we're having required drug discussions, if we find out that these drugs are given twice across the entire state in a year or something like that, then it does allow us to beg the question of why it should be required.
So Dr. Spade, this is Dr. Marin. Part of the answer to that is going to be, now that this quote-unquote drug box list applies to both pre-hospital environments as well as hospital environments, that singular view may not be as relevant. And so the dexamethasone specifically, and also the other part of this change will also result in the removal of the qualifier succinate away from methylprednisolone, which opens it up to both oral and IV routes, because before an oral route was not included on the state drug box. And so really this is meeting a request from hospital-based providers while as well offering some more latitude with what's going to be carried on an ambulance.
My point is if we make one or the other required, I'm just asking the question of it's still entirely relevant. What if neither of the drugs are ever given in the pre-hospital setting in a year in the state? And if we don't know that, we have easy access to that information now. My question is, if it's not given in the field, we're talking about the drug box now, not the scope of practice. I have no issue at all about the scope of practice and the crossover between in-hospital and pre-hospital. But like if the drug's never given, then what we're doing is we're mandating a whole bunch of expense, and so it's relevant every time we ask, because these are probably not commonly used drugs. So my question stands. I'm not speaking against the motion. It's that one of the reasons we should be doing AZ peers is so we can have information that's directly relevant when a question comes up like this. A rarely given drug, is it given at all? Because that is relevant to making, certainly that's relevant to the question of optional versus mandatory.
This is Dr. Johnson. And I guess it's just speaking anecdotally for the southeast, or I'm sorry, the northeast region of the state. We actually do use it with our asthmatic patients, because frequently we have people who are transported to the ED who take well over an hour by ground to get there. So we do have them start treating them in the field with steroids, even though it's not an immediate thing. It just has improved outcomes overall and shortened ED stays. So I can't speak for the rest of the state. I can't speak for the urban area, but I know we do use it relatively frequently in the rural areas in the northwest or northeast.
So, and kind of speaking to the original question, I'll kind of answer the other one.
Let me take the question away from the particular interest in any given single drug. Let me ask it this way: when stuff like this is going to come for us, since we and our agencies and the state support AZ peers, which between the agencies and the department's investment in AZ peers is a lot of resources, both financial and human resources. is there a reason when we're doing these for it not to be routine to at least get the data just to come from us on at least the quick snapshot of usage of the drug that we're discussing from AZ Pierce? Is that, I'm not making a motion. Is that a reasonable style?
So Dan, this is Gail. Was trying to answer those questions. Let me answer your question first, and I'll kind of go to the other comments. So we have run these reports in the past. I think it's been about 2 years since we've last run that. It's not a quick, easy report to run, so it does take some time, but certainly that is something that I think is a very reasonable request or recommendation moving forward. I think it's been at least 2 years since we last ran kind of the medication frequency report. That was part of what guided us moving away from dopamine, was looking at the utilization across the state, and also why we started moving a little bit towards push-dose epi was for those factors. So I think, yes, very reasonable request, and we are overdue for that. So we have written that down as a list of things to do. Unfortunately, it's just the way EMS agencies do document some of their medication. Sometimes it's not as easy of a report to pull as one would think it is, but certainly Anne and Bob can do that for us and have done it in the past. In regards to the medications as they cross over from the pre-hospital to hospital arena, I think if we were to find that it's not used in the pre-hospital setting, but we still want to maintain that in the hospital environment, that would be an option to put it back on simply Table 3. So Table 3 is for interfacility, for 3A is interfacility units, 3B is for hospital-related care. So that is certainly an option that would be kind of, I think, a good compromise for everyone to allow EMS providers working in a hospital setting to administer the medication. So I think really good discussion, and a good reminder that yes, we should be pulling that data, and it has been at least about 2 years. So thank you for bringing that forward.
The dexamethasone or the steroid treatment has been discussed to be put back on the TTTGs for asthma, correct?
I think it's still on there. It was taken off for anaphylaxis.
For anaphylaxis, but still on there. So I mean, it's listed as a required treatment within the asthma treatment category. So I assume it's being given quite often, just based on the fact that it's in most everyone's protocols to give a steroid when you're treating for asthma. Correct. But that, I mean, that's just sort of one piece of data without having the total number available.
And I see Dr. Godsdenker has his hand up as well.
No, thank you. This is Dr. Godsdenker. A quick question is regard to the dexamethasone. I see it's written down as 8 milligrams as a minimum supply. Just curious what that's based on. In the past, usually, I know 6 milligrams for COVID hypoxia and then 10 milligrams for otherwise adults. So just curious to see if there's something there.
I don't remember. Maybe I don't either.
For those on the line, there's some discussion of kind of, we're not sure where that number came from, but that is a good point. I think one of the conversations that had come up was potentially not going too high on the dose, because if that's your only steroid, then are you getting to a scenario that you're potentially carrying a higher dose than what people are administering? And I think clinically that was where a lot of agencies, when we had this discussion, where they kind of maxed out on their dose.
I do wonder also, and I'm just not familiar what the dosing is as it comes in vials. Maybe Brian Smith or others can kind of speak to that. I wonder if maybe that's where it came from. But to the point of kind of giving too much, I hear you, because we definitely utilize steroids pre-hospital as well. We oftentimes will use 125 methylprednisolone otherwise, but as an equivalent, I think if we can, I think it'd be appropriate to switch to 10 milligrams dexamethasone, but of course, open to hear opinions and thoughts.
They come in 8 milligram per 2 ml solution, it looks like.
Oh, that's probably one.
Okay, so it sounds like it comes in 8 milligram per 2 ml solution, Dr. Reisbaum. I see another hand raised as well.
Yeah, this is Raymond Pro, for my part. We utilize, we actually carry both dexamethasone and methylprednisolone. To add on to Dr. Godsdenker's question, we carry it and it comes in 10 milligrams in vials. So, yeah, I was kind of quite curious about the 8 milligrams also. That was going to be my question, but he beat me to it. So, yeah, and like I said, for us, we're over here on the west side, so usually retirement population. And we've kind of switched over to dexamethasone pretty much primarily, just due to like the elderly and the whole deal with the mineral corticoid receptor and just the speed and potency of it. It seems to work a little bit better. And we also have our protocol for anaphylaxis for kids. Wanted to add that in.
It's also worth pointing out that at least in the Central Arizona guidelines, we also have an indication of methylprednisolone for suspected cases of adrenal insufficiency. It hasn't been mentioned yet.
So is there a friendly amendment to increase that dose from 8 to 10, or is there a thought to keep that at 8 since Dr. Rice did find that one of the concentrations that it comes in is an 8 milligram dose per 2 ml?
I thought it's needed because they can always carry the 10 if they want.
Yeah, there's a 10 vial too, it looks like, on Boundary.
Because if they don't want to carry 8, they don't have to buy the 10 if they don't want to.
Happy to make that a friendly amendment if that works for the rest as well, from switching from 8 milligrams up to 10 milligrams.
Yeah, so this would be the minimum supply, so any agency could carry more. So I think.
Duly noted. I gotcha. Thank you.
Yes.
There's also 4 milligram vials, so you could have 2 4 milligram vials to meet your 8.
Yeah, there is a 10, but most of them are 4, 8, or 20.
I think 8 is reasonable.
Yeah, especially pre-hospital. If they need to give more at the hospital, they can.
Yeah, exactly.
Any further discussion on this item? Anyone opposed to the edit to the drug table, which is to combine as proposed on the screen, dexamethasone 8 milligram or methylprednisolone 125 milligram for EMTI or paramedic, please say nay. Any abstentions? All those in favor say aye.
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 And this is Frank Walter joining late. I apologize. I got tied up.
Thank you, Dr. Walter. Shelley, I see a hand raised.
Yeah, and the amendment was for dexamethasone to be 10 milligrams, not 8.
No, for 8 milligrams still.
Okay. Okay. Sorry. Oh, thanks.
Nope. Thank you for clarifying. All right. Next on the agenda, if I can get a motion to discuss, amend, and approve scheduling a special all-day session to approve the TTTG update. Okay, we've got a first and a second in the room from Dr. Katz-Marin and Dr. Johnson. I will give a little update for those of you who are not part of PMD as well. When we had our last PMD meeting that led into MDC, what we quickly realized at MDC was that the time frame that lapses between the committees, just like our conversation today about the 8 milligram dexamethasone dose, we had discussed this at length. And when you look at the volume of changes to the TTCGs, I think we all forgot the conversation and started having the conversation and discussions that we had already debated at length at the previous meeting. And so PMD has voted to have an all-day session to really kind of say, let's get together in person. We'll still obviously have a virtual option, but really just try to go through all the updates for the TTTG so we can get this done in one kind of meeting. The request for MDC is to consider whether this group would also be willing to have another a full-day MDC meeting in close proximity to PMD, not separated by 2 or 3 months. So that way we hopefully have the institutional memory of those conversations and we can get this updated. We really found that more of the state is utilizing these. I know Southern Arizona is going to be moving towards these. If they don't use the university guidelines, the Central Arizona guidelines, the medical component is based on the TTTGs. And we see Dr. Johnson saying they're using them in his area as well. So the great thing is we are seeing a lot of the states starting to utilize these, and we want to make sure that we have a really nice, thoughtful, but also kind of as time-effective as possible discussion. The way the meeting cycles pan out, it could take 2 years to go through this whole update, and so we wanted to propose that to the group. We understand it's asking everyone to give us a full day of their time, but hopefully this will be more time-effective for everyone. So that is the proposal, and I will open up for any discussions or thoughts.
I agree. I think it would be a much better use of our time to try to get it done all in one meeting. Every time we have separation in meetings, it just takes more more and more time to sort of regroup and get started again. So I think if we're talking about saving people time, I think doing it all together would be the best idea.
Is there a sort of a relief valve plan in case we actually supersede this allotted time?
And drop them off on your doorstep. Top of valve. That is a great point. Hopefully what we would ask is that people really spend some time ahead of the meeting to avoid that process. So, we have the PMD meeting is February 16th. If MBC does vote on that, we would try to look to do something within a few weeks of that if possible. A month is the maximum, and that way we can try to get that on people's calendars. But yes, we will, hopefully if there is any carryover, it's a smaller volume that we could do versus kind of the whole set. But yes, hopefully, my goal is that we really if people spend some time ahead of the meetings, kind of going through that. Everyone has access to the Google Drive, so we can make sure that Shelley resubmits that to all the committee members to say, please go into these, look at everyone's things, come up with your questions, so we can have a little bit more thoughtful conversation. And these are obviously going to be public meetings, so it will be available for anyone else that would like to participate in the public, so it wouldn't be closed to PMD or MDC members, but just want to make sure we try to get it on people's calendars as soon as possible.
But we would need a quorum.
We would need a quorum, yes. So if we don't have a quorum, then that would be the top of valve. So.
Want a motion?
We have the motion on the table, so we would just need any further discussion, or we could take a vote. All right, hearing no further discussion, anyone opposed to forming the all-day work group, please say nay. Hearing none, any abstentions? Hearing none, all those in favor say aye.
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 All right, the motion passes. I will work today with Shelley. We will get a date on the calendar, get that out to people, and make sure that that works. If that does not, obviously we do have to have a quorum, so we will get this out to people and get everyone RSVP'd as soon as possible to make sure we can meet quorum to have that go successfully.
Don't we have the date already selected?
That is for the PMD one, yes. I mean, one option would be to combine those, but I think that might be a little difficult because you'd have two different bodies, forums that would need to vote on it. The hope is that PMD will do more of the legwork and prep that for MDC, which is kind of historically how that's worked.
This is Dan. By the way, I think we almost struggled with a quorum today, so I would suggest that we send out a survey so that each of the voting members can hopefully be able to at least positively commit to being there. If you just pick a day, the likelihood we have quorum problems is pretty common.
Thank you, Dan. Yes, we can do that. Next on the agenda, we're going to discuss the national guideline for EMS field triage of injured patients. We went over this at length in the last two meetings. I will not go through this in detail with this committee today. First, a big thank you to the Education Committee, Drs. Munn and Rice, for putting together this training. I really appreciate the fact that this is in a format that has kind of audio recordings that can be uploaded directly to an agency's learning management system to allow someone to go through the training without simply hitting play and walking away. It truly engages the EMS provider in taking the training and hopefully gaining this information. For those of you that weren't on the first two meetings, this is the first substantial change to the field triage guidelines since 2011. When this was last published in 2011, STAB did formally endorse the update and actually published little pocket guides that went out across the state to EMS providers and hospitals. And so we really want to make sure that we do our due diligence of getting this information out there. So hopefully the trauma centers are starting to use this as well. Again, this is attached in your agenda. If you go to our current website, you can see both the PDF and PowerPoint versions. And then we're going to just do a last minute confirmation. I think I finally figured out how to share the LMS version, so we can distribute that out. So
do you have the link also? Give the link. If people want to view it before they decide to put it in their LMS, they may want to do that.
Okay.
So we can give the link, and the link will let you access the course and go through it. It doesn't track it in any way. And so if they want tracking in their agency, they have to upload it into their LMS. Okay. But they may want to view it before, so.
Yes, definitely both options would be great. So, really just a big thank you. You know, one of the things we look at is how much can we standardize some of the education that goes out to our EMS providers. If you look at the history in Arizona, starting with, you know, CCR, Epic TBI, and now this trauma triage, so this is really amazing education that can get put forward and be disseminated across the state. So, a big thank you to everyone that participates in those committees, and a thank you for putting together that training for us in that format. Any questions? Comments? All right. Hearing none, I will move on to a little bit more detail about the needs assessment.
I think we covered this one. I'll just chime in and say again, be on the lookout, please, for the strategic planning needs assessment that is going to be coming your way. We expect that to be distributed through the regions end of this month or early February. And thank you so much. I'll just say we have here the agenda item says is a needs assessment with a request for specific workforce training needs and priorities. We did do some surveying over the last year, and the feedback we got on some of the workforce needs did lead to increased funding for the regional councils, and so we are hopeful that if we get enough participation and feedback, that again, we will be able to prioritize resources moving forward. Thank you.
Yes, big thank you. And for anyone who's not signed up for our Gov Delivery communications, we try not to spam people. I think we do a pretty good job with that, but we really do try to communicate out key information to everyone. So just a reminder, if you are not signed up for the email distribution, we can show you how to get signed up for that as well. Last for our discussion and action items, Shelley keeps us on task with every 3 years. We do need to update our bylaws or review them for update. So I need a motion to discuss, amend, and approve forming a work group to review the bylaws. Thank you, Dr. Johnson, the first. Dr. Rice for a second. Any discussion?
Where are the bylaws supposed to approve?
They should be on the Bureau's website. If you go to our main website, I was just on there, and then you scroll to, it says EMS Council, MDT, and STAB on the left, and then when you go into the EMS advisory groups, you will see the bylaws under each section. So we'll take a vote first. Anyone opposed to forming a work group, please say nay. Any abstentions? All those in favor say aye.
Aye.
And now the hard part. Who wants to actually participate in the bylaws revision and review? Shelley usually makes this pretty painless. You'll get them ahead of time to review. We try to do it in one meeting, but.
Like what we did last time, a couple years ago.
Thank you. All right. We've got Franco and Jason. Thank you both for volunteering. All right.
And then I volunteer Jason.
Yeah, I'll volunteer.
And if anyone else would like to participate, please let Shelley know. We will happily add you to that group. So, all right. Are there any agenda items the group would like to consider for the next meeting? Hearing none, call to the public. All right, hearing none, in your agenda, there is a list of upcoming current events and educational opportunities, as well as a link to the Bureau's website for news and conferences and training program updates with CEs. Our next officially scheduled meeting will be May 18th, 2023 at 12 o'clock. Again, we will hopefully have another interim meeting here moving forward as well. If I can get a motion to adjourn. All right, the meeting is adjourned. Thank you very much. Thank you, Chef.